Hello everyone, I'm Dr. Sudhir Jain. I, along with my colleague Dr. Alpana Srivastav, are going to present a series of presentations on the interpretation of lung biopsy for evaluation of interstitial lung disease. This is the first presentation where I'm going to talk about the basic functional anatomy of the lung. We have relied extensively on the resources mentioned in this slide. We would recommend that all those who are interested in pathology of lung should go at least some of these resources. The term interstitial lung disease and diffuse parenchymal lung diseases have been used interchangeably. Technically, diffuse parenchymal lung disease seems to be a more appropriate terminology, but in the common usage, ILD is more prevalent. ILD or DPLD is a group of diseases that involve bilateral pulmonary parenchyma diffusely. Pulmonary parenchyma includes all structures distal to terminal bronchioles. That includes respiratory bronchioles, alveolar ducts, alveoli, including interstitium. Unlike tumor pathology, where one can arrive at a diagnosis either on histology alone or in conjunction with molecular studies, diagnosis of ILD is more challenging. The pathologist must try to answer the following questions. 1. Is it a disease with a defined diagnosis and therapy? For example, infection, sarcoidosis, mineral dust pneumoconiosis. If not, then can one predict the pathway of injury? That means either inhalational or immunologic. And thirdly, what are the treatment options? To achieve our objectives, not only we have to carefully examine the section of the tissue biopsy sample, but also have to take into account the clinical history, including history of past infections, drug intake, occupational history, history of drug abuse, and laboratory workup, especially for infections and connective tissue diseases. Number two, you have to look at the HRCT observations, and when you combine all these three, the histological pattern of injury, clinical history including lab work, and HRCT findings, you can knit a story and arrive at a final diagnosis. In order to understand the CT observations and the pattern of injury, it becomes necessary to understand the basic functional anatomy of lung. Respiratory system can be divided into two major categories. One is conducting zone, comprising of upper respiratory passages, bronchi, and terminal bronchiole. The function of the conducting zone is for the movement of air during tidal ventilation. Respiratory parenchyma comprises of respiratory bronchioles, alveolar ducts, alveoli, alveolar sacs, and the interstitium. The function of respiratory parenchyma is molecular diffusion of gases. It is the disease of respiratory parenchyma that we are concerned with while we are looking at interstitial lung disease. As mentioned in the previous slide, airways or conducting zone starts from nasal cavity, goes through the lung trachea, main stem bronchi, segmental bronchi, subsegmental bronchi, and bronchioles. Whereas parenchyma includes terminal bronchioles, respiratory bronchioles, alveolar ducts, alveolar sacs, and alveolar septi. Bronchi branch regularly, and the different levels of branches are called generations or orders. The first generation, that is trachea itself, is generation or order 0. Main bronchi are generation 1. Airways can also be divided into two types depending on the presence of cartilage in their wall. The cartilaginous, which include trachea, main bronchi, lobar bronchi, segmental and subsegmental bronchi, whereas the non-cartilaginous ones include bronchioles, terminal bronchioles, respiratory bronchioles, and alveolar ducts. This slide shows main features of main stem bronchi. Here are the characters of generation 2 or lobar bronchi. Right lobar divides into 10 segments on the right, and the left lobar divides into 8 segmental bronchi. Please note that for transbronchial lung biopsy, the approach is either through the lobar or through the segmental bronchi. Subsegmental bronchi are from 4th to 9th generations. That means some subsegmental bronchi will branch into some more additional subsegmental bronchi, and finally they will branch into terminal bronchi. Subsegmental bronchi branch into bronchioles which are non-cartilaginous. They are from 10th to 15th generation, and their lamina propria is directly connected to the lamina with the lung parenchyma. And remember, there is no fibrous sheath between the lamina propria of the bronchus and the lung parenchyma as it is in larger airways. The epithelial cells here start becoming cuboidal. The goblet cells and cilia are reduced in number. Terminal bronchioles are from 16th to 19th generation. The average diameter is 0.5 millimeter, and cilia and mucous glands begin to disappear completely, and terminal bronchiole are supposed to be the end of conducting airways. There are canals, interconnecting canals of Lambert that connect this generation of airways to provide collateral ventilation. This is a schematic view to show the generations of airways. Remember that up to 4th generation, the airways are visible on CT. Up to 9th generation, they are visible on HRCT. And up to 15th generation, they are visible on HRCT when they are diseased. Secondary lobule is the smallest lung unit that is surrounded by connective tissue septi, and that connective tissue septi is continuous with the pleura. It measures 1 to 2 centimeter and is made up of 5 to 15 acini that contain alveoli for gas exchange. The secondary lobule is supplied by a small bronchiole called terminal bronchiole at the center. Centrilobular arteries run parallel to it. Pulmonary vein and lymphatic run at the periphery of the lobule within the interlobular septi. Bronchiole and the artery that supply the secondary lobule are about 1 millimeter in diameter. This figure shows the schematic structure of a secondary pulmonary lobule. The terminal bronchiole supplies this part of parenchyma. This is the pleura, and this is the interlobular septum. See, the pulmonary arteriole parallels the terminal bronchiole, and the lymphatics and veins are present in the veins. Acinus is parenchyma supplied by a single respiratory bronchiole. It is 7 to 8 millimeter in size, and 3 to 24 acini form one secondary lobule. The primary lobule is parenchyma supplied by a single alveolar duct, and 4 to 5 pulmonary lobules form one pulmonary acinus. 85 to 95% of alveoli are covered by small pulmonary capillaries, and the cross-sectional area or surface area of these capillaries is approximately 70 square meters. There are approximately 300 million alveoli. They are between 75 microns to 300 microns in diameter, and most gaseous exchange takes place at the alveolar capillary membrane. This is a picture of normal alveolar structure of lung, though in this case some of the alveoli are hyperinflated and you see some condensation of fibrous connective tissue on one end. Remember that as a pathologist, I rarely get to see a normal alveolar tissue. This is the list of terminology that I use in HRCT. Reticulation is network of lines on HRCT which indicate thickening of the septi or the interstitium. Ground glass opacity is a hazy increase in lung density without obscuring the underlying vessels, suggesting inflammation or accumulation of fluid in the alveolar lumina. Nodules are small rounded opacities which can be categorized by their distribution: centrilobular, perilymphatic, etc. Honeycombing is a pattern of cystic air spaces often seen in the end stage lung disease, indicating severe fibrosis. Consolidation is a solid opacity obscuring the lung vessels, suggesting filling of the air spaces with fluid or cells. Mosaic attenuation is a patchy appearance of alternating areas of increased and decreased lung density, often seen in small airway diseases or in vascular abnormalities. Crazy paving appearance, a combination of ground glass opacity and interlobular septal thickening, creating a cobblestone pattern. Tree in bud is a branching pattern of small nodules and lines, often seen in infection and inflammatory processes. Air bronchogram is air-filled bronchi within a consolidated area, indicating patent airways. Thus, you would note that these terms or the HRCT observations can give you some information regarding the pathology or the lesion that is there in the lung. If there is a nodule, or there's accumulation of fluid or cells, or there's fibrosis. This is a schematic representation of the CT finding. When you see lines lining the secondary lobule, it represents interlobular thickening or fibrosis of the interlobular septi. And when you have these white lines crisscrossing the secondary lobular structure, means that there is interstitial thickening or interstitial fibrosis. Similarly, honeycombing, you have low density areas, and similarly in cyst also you have low density areas. This pictures gives you a nomenclature of the lymph nodes. We often get cryobiopsies or EBUS guided transbronchial needle aspiration from the lymph node. So mainly the lymph nodes are divided into superior mediastinal, includes level 1, 2, 3, and 4. Level 4 is one of the common lymph nodes that is sampled and submitted for examination. The aortic nodes, level 5 and level 6, and then inferior mediastinal 7, 8, and 9. 7 again is a common lymph node that is sampled. And then the pulmonary nodes, which are 10 is hilar, 11 is interlobar, 12 segmental, and 13 subsegmental. When we talk of histology, trachea, bronchi, and larger bronchioles are lined by ciliated columnar epithelium. Many goblet cells and submucous glands are seen in trachea. Their number diminishes with only a few goblet cells and glands in terminal bronchioles. Trachea has a ring of cartilage, while the bronchi have plates. The smooth musculus bronchi is present between the lamina propria and submucosa. Terminal bronchiole has no cartilage, but muscle layer is prominent. Respiratory bronchiole has flat cuboidal lining with only occasional pod of muscle. Alveoli are lined by two cell types. Type 1 cell, which is a flat squamous pneumocyte, and type 2 cell, which is a much larger granular pneumocyte. Type 1 pneumocyte gives, gives rise to type 2 pneumocyte. 95% of alveolar surface is made up of squamous pneumocytic cells. They are between 0.1 micron to 0.5 micron thick, and they are the major sites of gas exchange. 5% of the surface of alveoli composed of granular pneumocytic cells. They are cuboidal in shape with microvilli, and they are primary source of pulmonary surfactant, and they are involved in resorption of fluid in the dry alveolar spaces. Alveolar macrophages are seen in almost every case in smaller or larger numbers. They are also called type 3 cells. They remove bacteria and foreign particles, and they may originate as stem cell precursors in the bone marrow, and they migrate as monocytes through the blood and into the lungs. Interstitium surrounds, supports, and shapes the alveoli and capillaries. Is composed of gel-like substance and collagen fibers. It contains a tight space and loose space areas. Water content in loose space can increase by 30% before there is a significant change in pulmonary capillary pressure. Lymphatic drainage is easily exceeded. Collagen limits alveolar distensibility. Areas of scarring making for stiffer and non-compliant lungs. Canals of Lambert and pores of Kohn, they provide for collateral ventilation of different acini or primary lobules. They provide additional ventilation of blocked units. And this collateral ventilation may explain why diseases spread so quickly in the lung tissue.